Hello, and thank you for joining us for today's webinar. We're presenting on the application of LSVT LOUD and neurological conditions beyond Parkinson's disease. Today, your presenters will be myself, Elizabeth Peterson. I'm one of the LSVT LOUD training and certification faculty members and a speech-language pathologist. And I'm joined by my colleague, Angela Halpern, who's also one of the LSVT LOUD training and certification faculty members and the Chief Clinical Officer for LSVT LOUD, who is also a speech-language pathologist. So we're both very excited to be here today presenting on this very important topic. If you'd like to know a little bit more about our backgrounds and our biographies, we have those on the slideshow and in the handout that you'll receive or should have received earlier today. So you can take a look at that and dive in a little deeper if you'd like to know more. I'm just going to briefly go over the plan for the webinar so you know what to expect. So first I'll cover some brief logistics, and then Angela and myself will present the content on this topic, which will include some case studies. And then we'll save some time at the end to address any questions that we have from the audience. And at the very end of the webinar, once you exit, a survey should automatically pop up on your screen. It should be really short, just take a couple minutes, but we do appreciate if you can take the time to fill out that survey. It really helps us to know how we're doing, how we can improve, if you have other questions, what you'd like to see in the future. So we do encourage you to take that if you're able to. So in terms of logistics, right now everyone in the audience, your microphone is automatically muted, and that's just to make sure that we don't have background noise from the various environments where you're joining us. But there are a few ways to ask your questions, and you can do this during the webinar and then certainly at the end when we reserve it for that question and answer period. But you can do it by raising your hand, and so you can click on the hand icon on your webinar control panel, and then we'll be alerted that you have a question, and I'll call out your first and last name and unmute your microphone, and you can ask your question live to the group. You can also type in your question. So on your webinar control panel, you should see a question tab, and if you click on that, you can enter your question there, and then we'll receive the text of your question, and then I'll ask it out loud, and then either Angela or I will respond to it that way. And the third way, and this is really any time, but you can always email us. The email is info as in information. So info@lsvtglobal.com, and we can always make sure your question gets directed to the right person. I also want to point out that you do have a handout. So you should have received an email earlier today, unless you registered closer to the webinar time. But that email included a handout for the webinar here. If you didn't receive that, we can also send it after the webinar, but it's also available in your webinar control panel. You should see a handouts tab, and if you click on that, you can click on the link to the handout, and then you'll be able to download it to your computer and then print it out if you'd like that. So just to kind of let you know a couple of the logistics here today. And in terms of disclosures, so as I mentioned, Angela and I are both LSVT LOUD faculty members, and all LSVT LOUD faculty have both a financial and non-financial relationship with LSVT Global. Non-financial relationships include a preference for LSVT LOUD as a treatment technique, and then our financial relationships include that we're both employees of, and we receive lecture honorarium and travel reimbursement from LSVT Global. In terms of the CEUs, or continuing education, so this webinar is not ASHA or state registered for CEUs, but it may be used for self-reported CEU credit. So for ASHA, when you do your certification maintenance, you can either have ASHA-registered CEUs or non-ASHA registered. So you'll just want to retain your certificate that you'll receive after the webinar. Also the handout, so you have that for your records, and then you can still report this as continuing education activity. So if you do want a certificate, you will need to email us after this webinar. So it's webinars@lsvtglobal.com, just letting us know that you would like a certificate so you can self-report your activity here today. If you do want a certificate, you also need to make sure that you're in attendance for the full hour. We have to have that record for our own purposes and the event that we get audited. So just make sure you stay on for the full hour. And then if we do happen to go over, you can certainly exit the webinar at any time after that hour mark. So I do have a quick polling question that I'm going to bring up on your screen. We just want to know who's joining us today so that we know who we're speaking with and we can tailor the webinar best to the audience. So I'm going to launch it here, and let's make sure you can see it on your screen there. So if you can just select who you are, so either you're a person with a neurological condition or a friend or family member of someone with one, a speech language pathologist, non-LSVT LOUD certified, and then an LSVT LOUD certified clinician. Or if you don't fit those categories, feel free to click on other. And then again, we can make sure that we tailor it best to who's here today. So it looks like most people have voted. All right, so I'm going to go ahead and close the poll. And it looks like we mainly have speech language pathologists here today, so a mix of both LSVT LOUD certified and not, so that's great. So we'll tailor it the best that we can to who's here today, so thanks for doing that. In terms of learning objectives, so at the end of this webinar, the goal is that our SLP participants will be able to discuss how a voice treatment, so namely LSVT LOUD, based on principles of neuroplasticity, has the potential to improve voice and speech in individuals with dysarthria that's secondary to neurological diagnoses other than Parkinson's. Also explain the process for determining if a client with a diagnosis other than PD may be a good candidate for LSVT LOUD, and then also be able to discuss some specific examples of this application to conditions other than Parkinson's. So with that, I'm going to go ahead and turn it over to Angela, who's going to jump right into our content here.
Great, thanks so much, Beth. Can you actually, it looks like the slide skipped ahead too. Can you go back one, please? To the efficacious treatments. Perfect, thank you. I'm very happy to be here with everyone today. Thank you for joining us. And let's dig right into the topic here. So as SLPs, we have experience clinically, and we know by research that we read that in the presence of dysarthria, there's this potential to decrease speech intelligibility that can then interfere with functional communication and decrease quality of life for our patients. So as speech therapists working with these individuals with dysarthria, it's really essential that we make our treatment decisions based on treatment efficacy data to maximize treatment outcomes. So as therapists, we're all very familiar and learned in grad school with the term of evidence-based practice. And the reason I think this has become such a buzzword is because of the importance of it. Whether we're working with patients who have swallowing problems or language deficits or dysarthria, it really is our ethical responsibility as therapists to look at, for whatever treatment we're doing, what is the evidence behind those treatments available, and then provide our clients with information so they can then make those informed decisions based on the evidence of how effective is it, what's the long-term carryover, and really looking at that, not necessarily convenience of scheduling or those types of things. Next slide, please. So in addition to identifying these efficacious treatments, it's important for us not to just focus on those individual components of dysarthria. I mean, certainly we have to do that through our evaluations, but looking beyond to the person as a whole. So if someone has decreased respiration, not just thinking, I'm going to work on breathing exercises, but rather to look at that person and determine how does the decreased respiratory support for speech then impact their functional communication and quality of life, so we can then work towards functional improvement for that person. We observe clinically, and people with dysarthria report this negative impact that dysarthria can have on their quality of life. So for example, things like decreased intelligibility, decreased naturalness, encounters that they have of others' negative attitudes towards them or feel like they're being discriminated against. And, you know, we all get these reports from our patients of, I don't communicate as much. I've withdrawn from communication because it's difficult or embarrassing for them. So there are a lot of complexities to what's going on, and it can be challenging to treat. So we're looking at what are treatments that can help us help our patients in the most efficient and effective manner. And there's a couple of references for you here, and I thought Dixon had a good way of expressing this impact in her report. With it said resulting communication difficulties lead to changes in self-identity, relationships, social and emotional disruptions, and feelings of stigmatization. And then further went on to say that speech and language therapy interventions need to go beyond that specific speech impairment to address and promote psychosocial well-being. Next slide. So when we think about different types of treatment options, these options might include direct behavioral treatments where we're really wanting to restore or improve function. And then we're going to dig into that in more detail using LSVT LOUD as an example in just a bit. Treatments might focus on facilitating compensatory or workaround strategies to maximize the existing function. So for example, if someone has decreased respiratory laryngeal coordination or support, might be using shorter phrases to help to maximize their function. Education of individuals and their families regarding how to create the most conducive environment for communication. So helping through our education for people to maybe decrease competing background noise by turning off the TV when they want to have a conversation, speaking to someone in the same room or facing the individual they're speaking with. We might incorporate the use of augmentative communication devices. So some of those low-tech options, such as a letter board, providing the listener with a context for the word by having the speaker point to the first letter of the word, using picture or eye gaze boards. And then of course we have some of those high-tech computerized or synthesized speech options. And with these, because there's so many options for devices, it's important as SLPs that we either have familiarity with or refer to our colleagues who have familiarity with these devices to find what's most efficient and effective for each person. Next slide. Why are we using LSVT LOUD as a focus here? Well, we mentioned that one of the treatment options is that direct behavioral intervention. So for the purpose of this webinar, we're going to focus on LSVT LOUD as the direct behavioral intervention. LSVT LOUD was initially developed for people with Parkinson's disease and has continually, over the past 30 years, been proven to be effective for this population with multiple research studies by multiple groups around the world. While there is randomized controlled trial, well-established efficacy data for LSVT LOUD with Parkinson's, what we want to keep in mind as we go through this webinar is there's not that same large body of data when we're applying it to other neurodisorders and pediatric populations. So there's some case studies, some small group studies, but we're going to walk through this webinar how, as a clinician, you would decide if LSVT would be appropriate and how you make that decision together with your client. Next slide, please. We're going to look at, for cases of adults with acquired neurodisorders such as stroke, how LSVT LOUD might be used to restore residual function. And then for children with CP or Down syndrome, how we might use LSVT LOUD to establish that speech motor control. Next slide. LSVT LOUD is based on principles of neuroplasticity. It's an intensive exercise-based treatment approach. It can be a shift for sometimes us as speech therapists and for our patients to think of speech therapy as exercise. So let's take a look at why we would look at speech therapy as exercise and why exercise-based treatments can be effective. When we look at the research on basic science using animal models, we have seen through this that the value of exercise for rehabilitation has been established. So through this basic science work, key principles of exercise that drive activity-dependent neuroplasticity have been identified. And then further, not only have these been identified, but through this work, it's been demonstrated that exercise can improve brain functioning, and in some cases may even help to slow symptom progression. So all of us are shifting our thinking to this idea that exercise is medicine. It deserves a legitimate placement in that plethora of things that doctors are recommending for their patients. In fact, when my patients come to me and I've been doing an LSVT loud session, and at the end they say, whew, I feel like I've had a good workout, I really love that comment because it demonstrates that I feel like I've been doing what I need to do in therapy and really pushing and driving and incorporating my speech treatment as exercise. Next slide. LSVT LOUD incorporates some of the core principles of neuroplasticity through its key concepts. I'm going to introduce these here, and then we'll talk about them in a bit more detail. We have this idea of target. So the idea is we're going to increase amplitude across the motor speech system by a single treatment target of think loud. We have mode, intensive, and high effort. This is really an important component of neuroplasticity for long-lasting change. So getting that push and that drive with our patients. And then calibration. This involves helping people to feel comfortable with a new way that we're asking them to talk, and then giving them opportunities to practice that outside of the treatment room, always with our long-term goal of implementation of what we do in the treatment room into their functional world independently. So these key concepts of LSVT loud are relevant not only for Parkinson's, but also for a variety of neurological disorders and dysarthria types. Next slide, please. Let's look at these now a bit more specifically. So in some cases, when we think about this idea of voice, focusing just on voice, we think, well, some individuals with dysarthria may not necessarily have a softer voice. And so it might seem strange that voice isn't the main issue. I'm hearing more issues with articulation. Why would I want to focus on voice as that single target? Well, what we see is it's not necessarily just increasing loudness with voice as the source, but rather that using voice as a source can serve as our colleague Carol Bullock put it very nicely, a point of entry. So it can serve as the single motor organizer for the rest of the system. We're always targeting healthy voice productions that are within normal limits. So we never are training a voice that's too loud, tight, tense, or hyperfunctional. And if someone has a voice that's close to normal loudness levels, it's more of focusing on this idea of increasing loudness at the source of voice to then organize everything across the system, and we see increased effort to other areas such as articulation, respiration, which can then target some of those other things. Next slide. So then we see voice as a trigger. So clinically and in our research, voice can serve as this trigger to stimulate this enhanced effort and coordination across the motor speech system. So by focusing on this idea of increasing amplitude through increased loudness, loudness becomes a global variable. And what we see is a spreading of effects to improvements beyond just voice. So in our research and clinically, we see changes in articulation, respiration, a variety of areas across the motor speech system. So from a clinical point of view, the value is that we can optimize changes in speech intelligibility in a simple and feasible way for our patients. And from the research point of view, it's really interesting to see that by the single focus of voice, how that can really serve as this overall organizer across the motor speech system to get this spreading of effects. Next slide. So as I mentioned previously, this increasing amplitude at the level of the voice does not mean a voice that is too loud or strained. That's never LSVT loud. LSVT loud is always normal loudness with healthy voice quality. So throughout the session, the speech language pathologist is shaping and modeling this normal loudness with a healthy quality. And therapists spend a lot of time in an LSVT loud session using those shaping and modeling techniques to achieve that. Then what we see is, while keeping the focus simple for the clients by just having them think loud, so one single variable for the client, the therapist might also be modeling a deep breath, a more open mouth, more effort to the articulators, more natural speech and rate. And this makes the treatment as efficient and effective as possible. The cue to the patient, think loud, but the therapist is using all of their elegant clinical skills in the background to model and shape these target behaviors, getting that deeper breath, more open mouth, improved articulation, etc. Next slide, please. Then that second concept was this idea of mode of treatment, intensive and high effort. LSVT LOUD incorporates many of these key principles of neuroplasticity, some of which being repetition. There are repetitions of the exercises that are done, but not repetition just for the sake of repeating, repetition with a purpose. When we look at neuroplasticity, we see repetition is important. And with that purpose, if someone has achieved a target voice, then the therapist is always pushing for more. So they're adding dual tasks through other motor cognitive challenges that are added on top of that. Saliency is essential in treatment when we look at these principles of neuroplasticity. So in LSVT LOUD, we're not using boring cookie cutter workbooks where everyone's reading the same thing, because we see that doesn't generalize. Treatment materials need to be personalized and salient, so all reading and conversational activities are personalized to the client to maximize that carryover. This intensity and high effort is important for healthy and disordered motor systems, and it's really a key to affecting behavioral changes that last over time. And we've seen it can be applicable for adults and children. Next slide, please. And then that next key treatment component was calibration. So with calibration, this is essential for generalization. It's fantastic if we can get these great outcomes in our treatment room, but that's not someone's real world. Our goal as therapists is always that our patients take what they have learned in the treatment room with us and they carry it over into their real world for that maximum functional impact and improvements in quality of life. We see in Parkinson's disease that there's a sensory mismatch. So individuals with Parkinson's disease feel like they're talking more loudly than what they are. And so because when we get them to a normal loudness, it feels like a shout to them, we have to spend a lot of time in treatment helping them to readjust, to calibrate to what is normal loudness, and how to be able to internally generate that on their own, not just to a therapist's external cues. And that's one of the reasons that LSVT LOUD is intensive, the 4 times a week for 4 weeks, because it takes time to retrain that internal cue so our patients can do this on their own. And then when we think of those subtle neuropsych changes that can happen in Parkinson's disease, this is where it becomes even more important to have a single focus for efficiency and effectiveness. So people sometimes will say, well, do I have to incorporate calibration with other neurodisorders because they don't have that same sensory mismatch that people with Parkinson's have? Well, maybe not to the same degree, but you are asking these individuals to talk in a different way. You're asking them to increase effort required for improved speech. And so with calibration, it's giving feedback on what is that target voice so people can independently use it, and also giving them opportunities to practice it outside of the treatment room so that they can be independent. And throughout our LSVT treatment sessions, throughout the hierarchy, we're always incorporating different activities, cognitive activities, linguistic activities to help to target some of those challenges people might have as well. Next slide. Let's now move on to the how. How does a speech language pathologist determine if LSVT loud is appropriate? As I mentioned earlier, with individuals with Parkinson's disease, we have a wealth of data on the effectiveness of LSVT loud. But for these other disorders, we have maybe small group studies or case studies, or if you are maybe interested in applying LSVT loud to an individual with a unique neurodisorder, it may never have been tried before. So how do you determine in those situations when you don't have the wealth of the research evidence of how it might be appropriate for those individuals? So let's get into that. The first step is you are going to use your expertise as a clinician to go through the steps. And number one is your evaluation. So you're looking and thinking, what is the clinical diagnosis and what is the rationale for focusing on improving voice? However, keep in mind, as I mentioned earlier, there are some individuals with other neurodisorders who may walk through your door and voice doesn't strike you as the first issue or problem. So for some of those people, perhaps you're using this target of voice as that motor organizing theme to help to then improve articulation or other areas. Very important, you want to then determine if there are any medical contraindications. So for example, for LSVT loud, because it's intensive and high effort, it would be contraindicated to apply that to individuals with ALS or myasthenia gravis. Also, we would not want to use LSVT loud for individuals with multiple sclerosis when they are in an exacerbation. We would only use it in remission. And there's other disorders that will fall into this category as well. So you're going to think through and determine if there are any medical contraindications. If people have any cardiac or respiratory issues, you're going to want to get clearance from their doctor because you are using high phonatory respiratory effort for this treatment. And I think it's helpful with these when you're talking with the medical team and working together as a team to explain what the treatment does, because sometimes a physician may say, well, speech therapy, once again, not thinking of it as exercise. Yeah, there's no issues. So explaining it's high effort respiratory phonatory treatment. If someone has cardiac issues and you might be thinking of incorporating isometrics to help get vocal fold adduction, you know, explaining, might do isometrics similar to a Valsalva. So basically you're giving that framework as you're working together with the team to see if there are any of those contraindications. And then looking at, is there a good clinical rationale based on the physiology? If yes, then move forward and try some stimulability testing. So we'll go to that step next. With stimulability, you would have first collected any of your baseline data. So meaning no cues, just seeing how are people, what's their loudness level. If you have them sustain phonation, how long can they hold it out? So you would have first collected some baseline information with no cues from you. But then when you're thinking about application of LSVT loud, the question is, does loud as a single motor organizer have an impact? So does it have a positive impact on intelligibility and communication? Does it affect voice quality, articulatory precision? What about prosody? What about rate? So here in stimulability, we're going to start to be a little more dynamic during our assessment and provide some cues. Next slide. So through our models and our cues, we're going to ask individuals to do some sustained phonation. Ah, and we would model increased loudness and ask them to do it with increased loudness and hold it as long as they can. We would be looking at how can they do with pitch exercises through modeling with increased loudness. What happens to voice quality? Does it improve? So does loud have an impact? Does it help with respiratory laryngeal coordination? Does it serve to help coordinate that system? And then we would do some short phrases, doing multiple repetitions with model and cues for increased loudness, and see if that has an impact. As I mentioned earlier, you might also be incorporating isometric exercises if there's no contraindications to that. You might be using any of the other voice techniques that you use with some of your other voice clients. So perhaps you're modeling some easy onset with that louder voice, or a ha. So you're pulling out all the stops. You're using your models, your cues, your motivation during the session to see what is the impact on intelligibility, quality with increased loudness. Next slide. Some considerations throughout this. Don't be discouraged if initially the client is minimally stimulable in that first testing session. Unlike in Parkinson's disease, where that physiological substrate's intact and we can see this immediate wow improvement with stimulability, for some of these other neuro disorders, it may take a little bit more time. So we say to consider a week of trial treatment as your extended stimulability testing. So you do your first session and then try LSVT LOUD for week 1 and use it as that extended stimulability testing. For some clients, it may take a little bit longer for some of those skills to kick in. Follow your clinical intuition, give it a chance, see what happens. Many times these clients, maybe other things haven't worked, so you're giving it a week and then you're seeing what the impact could be. And throughout that, you're going to be quantifying, documenting what types of changes do you see as you go throughout. Some clients may need a little preconditioning before they're ready for LSVT LOUD. So Beth is going to be presenting some case studies for you, one of which is a teenager with autism, and there was some preconditioning that went into that before getting ready for the LSVT LOUD treatment. Next slide. And then in that initial treatment process, as I said, you want to try 1 week of LSVT LOUD, so 4 consecutive sessions, and evaluate as you go through what is the impact. Does the client understand the instructions? Can they follow through? Do they seem motivated? Do they seem engaged? Are you seeing improvement across the motor speech system? Is LSVT LOUD being effective? At the end of that week, sit down with your client, the client's family, and discuss. What have you seen in your data? Have you seen improvement? Show that to the client. What do they think? How do they feel? What's their evaluation of the situation? Next slide. And through documenting, you would be documenting, are there changes in phonation duration? Has loudness changed? Is it easier for them to do some of the pitch exercises? Do they need less cueing than they needed at the beginning of the week? And as you've monitored that progress across the week, it's also your perception of voice quality, intelligibility, the family's perception of what's happening at home, and then of course the client's perception of the impact that this is having on their functional communication. And through all of that, then the two of you together with the family, if appropriate, would decide, yep, this is working great, let's move on to and complete LSVT LOUD, or perhaps you might say, this doesn't really seem to be having an impact, so let's discuss what we're going to do next and go a different direction. So that will be client to client and really based on your expertise as a clinician. Well, I'm now going to turn it back over to Beth, now that I've laid that foundation, and she's going to take you through some specific examples of application and stimulability testing.
All right, great. Thanks so much, Angela, for that nice rationale for why LSVT LOUD may be appropriate, and then also walking us through how to decide if your client may be an appropriate candidate. So yes, now I'll switch gears and talk about some of the examples of applications that have been done using LSVT LOUD with other populations. And as Angela mentioned, the research that's been done for these other populations is primarily case studies or small group designs. So we don't have the same wealth of data as we do with Parkinson's, but still some nice data out there to show that it could potentially work with these other populations. So here are some applications that have been studied. So Parkinson plus, or now known more commonly as atypical Parkinson's. So post-surgery, such as deep brain stimulation. Stroke, which I'll show you in the webinar here today. Some cases of multiple sclerosis. We'll show you that here today also. Ataxia, cerebral palsy and Down syndrome. So in the pediatric populations. And so we have some, we'll have a case study here to show you. We're actually a small group designed for the cerebral palsy group. And also aging voice could potentially be another candidate for this therapy. So we'll walk you through some of these studies that have been done and show you some of the pre-post either audio, and I think we have a couple video samples in here for you too, so that you can get an idea of if it may work for these other populations. So we always have the caution that it's going to be very individual for whether or not it's going to work for your client. And that's why it's so important to follow those steps that Angela was talking about in terms of your evaluation and the stimulability testing, because not everybody with multiple sclerosis or post-stroke is going to be a good candidate. So it is important to really still individualize these, but it is nice to have some of that data to show, oh, it did work for this client, maybe it can work for my client with that same type of disorder. So just keep that in mind as we're going through some of these examples here. So stroke is the first one that we'll present here today, and this is a leading cause of disability in the US, and dysarthria can interfere with communication following a stroke. So 54% of acquired communication disorders are comprised as occurring with stroke, and that's in the literature here that you see on your slides. So we'll walk you through a case study that was done, and this is a young man. He was 37 years old and had a left hemisphere hemorrhagic stroke resulting in Broca's aphasia. And so the cause of the trauma was an artery was punctured during an embolectomy. And when you hear, actually I have an audio sample for him, and this was done 3 years after the trauma. And we'll hear an audio of him before and after receiving LSVT LOUD. So we'll go ahead and take a look, or I should say a listen here on the next slide, to what he sounded like both pre-treatment and post-treatment, and then we'll point out some things with his sample.
Correct. What problems do you have talking?
Loud, no. I hear, I don't know, here.
Okay. Do this for me. Take a deep breath and say ah for as long as you can. Okay. Count for me from 1 to 25.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25.
Great. Do you feel that people have a hard time understanding you often?
Yes.
Okay.
Okay, so now you'll hear his post LSVT LOUD.
His date.
24th of May.
Okay, do this for me. Take a deep breath and say ah for as long as you can. Okay, now count from 1 to 25.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25.
You have had 16 sessions of speech therapy with Cynthia.
Yes.
Is it true? It is indeed. Have you noticed any changes?
Yes.
Okay, tell me about that.
Cool. I get no, whispering.
Do you think it's easier for people to understand?
Yes.
Has it?
Okay, so I think you could hear some nice differences primarily in articulation with him. We could also hear it in his vocal quality. And again, so he received LSVT loud, so only focused on voice and that healthy vocal loudness. And so it's pretty neat to see or hear that spread of effects that Angela was talking about, using loudness kind of as that trigger. So again, for him, I think the main one that's probably most audible is that articulation. And so someone initially may think, well, why would I try a treatment focused on loudness if his primary concern and your primary concern as a clinician is articulation? And so you can see that spillover from working on that healthy vocal loudness into his articulation. So that was an example of someone stroke pre to post who had a really good result with LSVT loud. You can also hear, if he continued on and he talks more about, kind of his confidence, and you could hear that with him, saying that people understand him better. He's not having to whisper, or noticing that he's not whispering anymore. So pretty neat to see that with this individual. All right, so some lessons or takeaways with stroke. So shaping good quality loudness can be challenging with this population, and change may occur more slowly than in people with Parkinson's. So if you are an SLP who's worked with someone with Parkinson's, you probably know that as soon as you stimulate them for loudness, you can see these changes right away in your treatment room. And a big component of LSVT loud is to make sure you're calibrating them so that those changes that you see day one walk out of the treatment room. You may not see those same, kind of gigantic leaps in improvement on day one with these individuals with stroke. And that's also why it's important, when Angela was talking about the stimulability testing, to not just give up and think, oh, it won't work for this patient. So that's why we say with stimulability testing, if you see anything or hear anything that you think may improve throughout the course of treatment, then go ahead and try, because with this population, you may not see those improvements right away like you do for Parkinson's. So there also are some considerations if aphasia is present. So likely you're still going to have to do some language therapy with these individuals, and they'll continue to do that. So that would be something that you would do separately from LSVT loud. I mean, of course, you can use some cognitive exercises like we do during the hierarchy portions, but if your focus is on language or the cognition, then that would be something that you would probably have to continue doing with this population as well. So another population that's been looked at is cerebral palsy. And dysarthria is common in people with CP, and typically it's characterized by hypernasality, breathy voice quality, a reduction in loudness, and rate abnormalities. So Dr. Fox has done a lot of the research with kids with cerebral palsy and Down syndrome, and so we'll go ahead and look at some of the research she did with Dr. Carol Bullock. So these are some pre-post. These are again some audio samples. And what you see is 1 through 4, and I'll play them in order. These are all kids that have been treated with LSVT loud, and we'll hear their pre and post audio sample. And then the 5th sample is a little girl who didn't receive the treatment, and that's just to show over the course of the month that we didn't hear any changes in her voice and speech, whereas these other ones, after receiving treatment, after that month-long period of time, you could hear the changes. So let's go ahead and take a listen to some of these. So first I'm going to play number 1 here. So it's a young boy, 7 years, 10 months, and you'll hear his pre and then his post. Oops.
Pair 8, sample A. Bye, mommy and puppy. Bye, mommy and puppy. Bye, mommy and puppy. Sample B. Bye, mommy and puppy. Bye, mommy and puppy. Bye, mommy and puppy.
All right, so some nice changes for him, and we'll look at, now we're on sample 2 here.
Pair 6, sample A. The blue spot is on the key. The blue spot is on the key. The blue spot is on the key.
Sample B.
The blue spot is on the key. The blue spot is on the key. The blue spot is on the key.
All right, so with her, you can also hear those nice changes in loudness from pre to post. Here's sample 3, so this is a young boy, 6 years, 1 month.
Pair 9, sample A.
The blue spot is on the key. The blue spot is on the key. The blue spot is on the key.
Sample B.
The blue spot is on the key. The blue spot is on the key. The blue spot is on the key.
Okay, so you could hear those nice changes in loudness and then articulation for that one too. So this is number 4. So this is another young boy, 7 years, 7 months. So we'll go ahead and listen to his pre to post.
Sample B. Pair 7, sample A.
Puppy, puppy, puppy.
So he had a shorter utterance length, so he was just saying puppy from those sentences, but you could again still hear the change even at just that word level and the quality and loudness for him. And then as I mentioned, this 5th one, so this is a little girl, she was not treated during the study. She received treatment afterwards, but she was one of the controls with cerebral palsy so that we could hear that there was no difference pre to post. So we'll go ahead and listen to her. She was 6 years, 7 months. Shoot, let's make sure I can get it. Sorry, the audio is overlapping, so I don't know if I'm able to click it, but we'll go ahead and listen to her treatment video if I can't get this audio to play right. Oh, okay, we'll try one more time. Okay, so I'm going to go ahead and move on to her treatment video. So she didn't receive treatment during the study, but everyone that didn't receive treatment during the study was able to receive treatment at the end of the study. So we can go ahead and look at her. This is one of her treatment sessions, and we can see kind of what treatment looks like with a child with CP, doing LSVT loud the same way as you would with someone with Parkinson's. So with kids, you can imagine you have to make it, you know, more fun, more engaging for them, to just keep them engaged that whole hour, but they do the same full protocol that the individuals with Parkinson's and our other adult clients do.
Oh, perfect, Miss Katie. So what we're going to do is you're going to give me a nice big Whoa! What did you get?
So you could see Katie really engaged in the treatment, doing the same exercises again that individuals with Parkinson's do. So really cool to see that with the kiddos, that they can also sit through that hour session and really make some nice progress. Oh. So another population that has been studied is Down syndrome. So communication disorders are also common, frequently including dysarthria. And typically with Down syndrome, we're seeing that therapy focuses on cognitive linguistic deficits and hadn't focused so much on vocal loudness. So speech treatments in Down syndrome have received little attention, even though those speech deficits do have a negative impact on their overall quality of life. So some lessons with both these pediatric populations: that shaping that good quality loudness can be challenging. With these populations, change may occur more slowly also than people with Parkinson's. And then there's also some considerations if language and cognitive impairment is present. So you might have more structured dialogues with these kiddos to try to not focus or get so caught up in the cognitive impairments that are there. And then also the timing of treatment. So with these kids, again, it's not going to be that LSVT LOUD is kind of a one-shot deal and all they'll need. They'll likely need continuous therapy in other areas. But as Angela showed you on that slide with Dr. Bullock, she said that voice can be a good point of entry. So it might be that you've tried, working on respiration or language or cognition and hadn't thought to use voice and loudness. Maybe that's another tool in your toolbox that you can try with these kiddos to try to trigger a spread of effects or just get that better respiration through focusing on that vocal loudness. And you could hear some nice differences in those pre to post subjects that we heard with cerebral palsy. Okay, so another case that was looked at was multiple sclerosis, and with this disorder, about 40 to 45% suffer from dysarthria. It's most commonly spastic ataxic dysarthria, and some of the more prominent features include impaired loudness, a breathy or harsh voice quality, vocal instability, and imprecise articulation. With this population, more treatment research is needed, but we have looked into a couple cases with multiple sclerosis, and we'll listen to one of the cases here today. So the one you'll hear, so we have an audio sample. She was 46 years old at the time she received treatment. So progressive MS with superimposed exacerbations. So as Angela mentioned, with MS, you would only want to treat in periods of relapse, and so that's what she was in relapse when she had treatment. 12 years since the initial diagnosis, she was in a motorized cart. Her cognition was deemed within normal limits. So we'll go ahead and listen to her sample. So some of the pre-treatment kind of symptoms or signs that you could hear with her: she had a weak voice, intermittent breathy voice, and you can observe deterioration of her vocal loudness with extended use. And she may even mention that in her audio clip here. On the ENT exam, there were no laryngeal anomalies noted. She had good speech production and no lesions. So let's go ahead and listen to her audio sample. So this is, again, pre to post LSVT LOUD.
When did you first notice anything in your speech or your voice?
I was hospitalized 2 years ago in January, and I was in a rehab center for a month, and I got passes to go out to the chorus meetings that we have, and I was very, very weak in singing. Had no strength at all, and it was mostly abdominal.
So you noticed that it was difficult for you to...
I could produce very little sound.
Do this for me if you would. Take a deep breath and say ah for as long as you can. Would you say MS has caused you to talk less?
Probably, especially when I'm fatigued. I can get to the point that I can't even talk above a whisper.
Okay, now you hear her post.
Do this for me if you would. Take a deep breath and say ah for as long as you can.
speech or voice changed as a result of speech therapy? Oh, before I would never have even considered talking in front of a group, especially without a microphone. I would have most likely given my announcement to the president and had her read it for me.
Okay, so with her, I think you could hear some nice differences in her loudness and quality too. And then with her also that confidence. She really had a lot of confidence after receiving treatment. So something to note with her, there was another case study with MS who did not have the same type of outcome as her, where the other one was able to get good loudness, but she had to be externally cued. So one thing can be the timing of treatment. So if you can get them earlier on before the speech has progressed or declined so much that it can be harder to bring them back up, that can be, you know, a good factor to look for when you're looking into doing the treatment. But we'll go ahead and look at some of her post-treatment changes. You could hear that increased loudness, decreased fatigue. She also mentioned improved singing strength. As I mentioned, you could really hear that confidence. And then she also had a marked improvement in both the strength of the voice and the adductor tone, as seen on her ENT exam. So some considerations with this population. So again, making sure you're treating during periods of remission, not relapse or exacerbation. Timing of treatment, as I mentioned, can matter. So trying to get in earlier in the course of the disease, and take this on a case-by-case basis. So even the other case that didn't have, you know, kind of these same results as this client that you just heard, she still noted that, you know, her function was improved because she was able to be cued for loudness, and that was important for her because even with the cue, then she could get out what she wanted to say. So this next one was a young adult with autism. So this one's a little longer, so I'll just kind of go through this one quickly. So he was 18 years old. He had severe cognitive, language, and sensory motor disorders. He also had a significant limited use of functional intelligible vocabulary. And the parent reported concerns were that he had weak breath control, reduced loudness, limited clarity when attempting to speak, didn't have enough breath, had soft speech, monotone, and no confidence when speaking. And so 3 SLPs were working with him and noted that some of the same things. So reduced breath support and control, reduced intelligibility, reduced loudness, monotone, a faster rate of speech, and his output was limited to words or short phrases. So the SLP originally thought, you know, through some of the negative prognostic variables, because he wasn't initially stimulable for LSVT loud. He wasn't able to respond to cues to increase loudness. He was 16 years old at the time that she was assessing him, and because he did have a severe speech and language disorder. But on the positive side, he was very motivated, as were his parents, to be able to do that verbal communication, and they were very open to try the week of treatment to determine his candidacy. So he was using a letter board. So when he was asked about his goals, he had said, I have to be honest, my finding the ability to start and carry full conversations is my intent for the future. So he had that motivation. He wanted to have that verbal communication. And during his first session, so he expressed, my first LSVT pleasant video session with Jessica was more successful than I thought it would be. The security of the sounds I was making was much clearer. The letterboard still gives me confidence. So still using a letterboard, but trying to do more verbal communication. And at the end of treatment, so he did end up going through a full course of LSVT loud. He did make some significant gains in maximum inflammation time and his speech loudness. And these were also observed for speech, though there was some variability due to some of that cognitive and linguistic disorder going on as well. But the parent reported great improvement across some perceptual variables, such as the breathing associated with speech, his overall intelligibility, his initiating a conversation and participating, noted from pre to post. And he noted improvements in his ease of speech production, his ability to breathe and control speech, having more of that confidence. That can be such a huge thing, giving people that confidence and working to improve their overall function. And so that it still made a big difference to him across the course of treatment. We'll go to his next slide there. So he did have some adaptations to help accommodate some of those other difficulties going on. So she did give him some breaks in motor practice. He had some longer sessions. She added some weeks to treatment, and also she had to focus some on behavior management. And she made some modifications for language and the reading level that he was on in the hierarchy. She gave him a lot of additional feedback and reinforcement and counseling to really help increase his overall confidence in his verbal communication. So these are some neat findings to show that we have some preliminary support that LSVT LOUD may work for individuals with autism. Again, this would be a very case-by-case basis to see if a client would be able to handle the treatment and if we do see some positive stimulability testing results. But something, again, to keep in mind for this population. All right, and his case was actually published in the Huffington Post, so you can take a look at this link if you're interested in learning more about that case. So I know we're here at the end of our hour, and so we just have a couple slides on atypical Parkinsonism that I'm gonna just leave in the slideshow, and we actually have an upcoming webinar specifically on atypical Parkinson, so we'll get more in depth in a future webinar, but just some bullet points and some takeaways for these individuals as well. All right, so I just want to wrap up and present some general considerations. So LSVT LOUD is not for everyone, but as I've mentioned a couple times, you can think of it as another tool in your toolbox. So if you've tried other things that haven't worked, maybe LSVT LOUD could be a good point of entry to make a difference or to kind of trigger differences in other areas. So definitely something to consider for individuals with other disorders as well. So those stimulability testing results and your clinical judgment, as well as talking with the client and family, should guide your decision on whether or not to progress with treatment. Some diagnoses are contraindicated that Angela mentioned. So myasthenia gravis, ALS, multiple sclerosis, and exacerbation are three that we would say definitely not appropriate for those clients, but for others, certainly following the steps Angela mentioned can help you decide if maybe they would be a good candidate. So since we are at the end of our hour, if you need to sign off, feel free to sign off. You've been on for the hour and you'll get that credit. If you do want to stay on and ask any questions, you can certainly do that. To exit out of the webinar, you just click the X on the top right corner of your screen, and then that survey should automatically pop up. But if you do want to stay on for any questions, you can either type a question in the question box or raise your hand on your webinar control panel. Or you can also email info@lsvtglobal.com if you think of any questions after the webinar here today. So we'll open it up for questions now, just as I put up these last two slides, and we'll see if anyone has any questions on this topic. So the next public webinar will be on the application of LSVT BIG to advance in atypical Parkinson's, and so that will be on August 21st. So if you're interested in that, feel free to check out the website. So if you do blog.lsvtglobal.com, you'll see a list of all the public webinars. And I want to say the September public webinar is the application of LSVT LOUD to these advanced and atypical Parkinson's disease. All right, and this is just some contact information again if you do have any questions. Okay, so we did have a question come through. Let me just pull this up. Okay, so have clinicians been successful in getting reimbursed for treating patients with LSVT LOUD and other conditions? So that's a really great question. And so we have gotten feedback from clinicians and faculty members that have done LSVT LOUD with other populations who have had good success with getting reimbursement. So part of the reason is because just as you would with LSVT LOUD with Parkinson's, is that documentation is so clear. And so we have that very clear objective data pre to post when we're looking at DBSPL, frequency, duration. And so we have that pre to post for any population that we're working with. And so it's easy to get that objective data. People are also using perceptual rating scales, both for the client and for the family members. And so they have that data to include. And then we've had clinicians that say that they also will, if there is a case study or a small group design, you can also submit that research as part of your documentation so that you have that support. But as long as they're showing that progress from pre to post and that functional impact or impact on safety, we've had good success with clinicians getting reimbursed, again, both out in the community and then also within our LSVT LOUD faculty. Okay, so here's another question that came in, and Angela, if you want to take this one. So she's asking, is there any data about stuttering?
To my knowledge, I haven't seen a research study on stuttering. I can tell you clinically, what I've seen and what other clinicians have reported is, and it depends on if the stuttering is a true stutter, or sometimes clients will report stuttering based on palilalia. And so let's talk first about when someone actually has a stutter. So because of the common links with when we look at neurologically, some of the origins of stuttering and Parkinson's with that basal ganglia involvement, you know, we do see sometimes people report, oh, I was a stutterer as a child, and then it went away, and now that I've had Parkinson's, the stutter came back. I had a gentleman I worked with, and what I was hoping might happen is with this increased effort across the system, that might help him with the stutter. And initially there was a bit of an impact, but then as he began to habituate and incorporate LSVT LOUD, it didn't have as much of an impact on the stutter. So we went through LSVT LOUD, got his voice in a place it needed to be, and then I referred him to one of my colleagues who is a fluency specialist, and he worked with her for those other issues. Then having seen individuals who have palilalia, that's more of a festination of speech. So someone saying, I want to go to the store. How are you doing today? So that's a little bit different than a stutter, and that happens typically later in the disease process, but patients will many times say it's a stutter. With those individuals, once again, if it's really mild, we would say, you know, you could try LSVT LOUD first, see if that increased effort across the system can have a positive impact on rate. But if the palilalia is pretty severe, we have a case study of a gentleman who was unintelligible pre, did a couple weeks of LSVT LOUD just on LSVT LOUD so he could focus on getting the fundamentals, incorporating LOUD, and then we added a letter board. So he would scan, point to the first letter of the word he wanted to say, and that significantly slowed his rate so that he was then able to be 100% intelligible following, and he was able to generalize. Now he was a very had a high level of cognition, so he was able to do that multitasking. Tried that with another person who was more cognitively impaired, and it was difficult for them to multitask to do that. Beth, I don't know if you have any other clinical examples.
No, I think that was a nice comprehensive answer there. Okay, so, and it looks like there, oh, we do have one more. So let me see, there's a hand raised. Okay, so Constantina Sar, I'm going to unmute your microphone. Oh, it might have been a mistake because I think the hand went down. Okay, so I don't see any other questions coming through, but if you do have a question, again, feel free to email us, so info@lsvtglobal.com. You can also write a question on the survey and we'll get back to you there so that we can make sure we address everyone's questions. So I want to thank Angela for presenting here tonight or today, depending on where you are, and then thanking everyone in the audience for being here with us today, and we hope you can join us again for a future webinar. All right, take care. Thank you.